right, so I'm just going to start out with the timeline and talk a little bit about the beginning of the project and let you look at the timeline while I'm describing how we got started. And these issues will pop up as I move through the presentation. So we actually got started doing this work in 2007, and it was Kathleen Quinn and her predecessor, a gentleman who was in the School of Medicine for a long time named Weldon Webb, who were at a HRSA conference and were introduced to folks from the Shep Center at the University of North Carolina. And the Shep Center has been in existence since the late 1970s, so long before we worked online primarily. And it is an interesting state in that they've done an annual or regular analysis of the occupations and professions in their healthcare workforce in a collegial set of relationships, since the late 1970s. So they don't require statute to get folks to respond to minimum data set surveys and describe their workplace and work activity and demographic characteristics. It's just the culture there to do this work. So it's inspiring, and it's given a lot of structure to the way that healthcare workforce analysis happens in the United States. So they had this experience, came to OSEDA, the Office of Social and Economic Data Analysis that Sherry mentioned, which for many years at MU was in extension, and came back to Columbia and said, we know we need to do this here in Missouri. Let's start talking about how we can move this idea forward. And the first thing that we did was to convene an advisory group with a broad set of skills and interests, and started the work with the idea that it would be collegial and that it would be ongoing and that it would inform policy development at the state and community level here in Missouri. The next thing that we did was start with the information that we had at the time, which were public release files from the Division of Professional Registration in the state of Missouri, now in the Department of Insurance, and just look at what that administrative data in a public release format looked like and shape that into some web application presentations, framing it as a pilot or a prototype as a way to get started. And I'll talk a little bit more about our advisory group work here shortly. So I'm sure everyone on this call has probably looked at this map or one from a year or two or so ago, but I just wanted to start with this moment of context. And these are our healthcare workforce shortage areas as defined by HRSA. And this was just released this month, so this is fresh information. And I wanted to set Missouri against the rest of the country so that we can admire how similarly our state reflects or mirrors what much of the rest of the country looks like. We have big patches of rural and underserved areas, a very few places that are considered to have an adequate workforce across an entire county, and sort of our larger metro areas that are generally covered. And then I also wanted to share some of what it looks like when we look at licensure data to see where primary care physicians, in this case, are distributed across the state. This is a simple rate per 10,000, and the gray counties are counties that were not recording a license based in that county for any of the primary care specialties. And it looks probably much like you would think that it would look. in terms of being able to pick out our large population centers and with less accessibility throughout the rest of the state. So this is a very busy slide, and I realize it's a busy slide. It's more in here for sharing for resources down the road, but I do want to make a couple points about it. One is we're not doing healthcare workforce analysis here in Missouri in a vacuum. In fact, there's a decades-old body of work and research and literature and some standards that are fairly well accepted across both the public sector when it thinks about policy and within professional associations in terms of addressing their own workforces. So we have largely modeled what we're doing here in Missouri based in the HRSA work. HRSA has its own efforts. It funds Technical Assistance Center TACs in a couple different places around the country. The one in New York at SUNY Albany is very focused on supporting other states in development of their workforce analytical capacity. The Nursing Association at the national level and with its state memberships perhaps leads the way in its commitment to understanding workforce characteristics in a longitudinal context. The National Governors Association has a division committed to understanding workforce trends. So it is an understood issue and one for which it's very useful to engage with, model from, and think about consistency between states to understand what's going on and what you can do policy-wise within your own state. So I would point out that the University of Michigan specifically has a behavioral health workforce research center that is very focused on distribution of literature and research around their behavioral health workforce and other research from around the country and the world. And the other states that I picked and are included on here were more for the purpose of showing the sort of diversity of work that happens. The University of Washington Center is another one of the HRSA funded healthcare workforce centers. And they have a very good nexus there at that particular center with their rural track studies also. So when Missouri, when Missouri decided to adopt the particular model that we were going to work from, and as I mentioned, we put together an advisory group and started convening and talking right away. It was gratifying to see that we kind of got it right. Here is what the Healthcare Workforce TAC suggests in this very nice policy brief on how to get states going in terms of working with their licensing bodies to understand the healthcare workforce and to facilitate data collection. And they lifted up a set of potential collaborators, and we concur. These are very important groups to ensure that you have at the table, understand their needs, and use that space to encourage dialogue and collaboration sort of across the bodies and associations and groups that move across the full spectrum from training to managing and supporting the workforce in the field. And it's important also to think of it as both a horizontal and a vertical integration of interests and groups to be able to do this work successfully. So in Missouri right now, these are the primary categories that we have as part of our advisory group. And I'm using the group the word group right now very intentionally as I'll talk about here in a minute, we are in a period of doing some long-range and strategic planning around what we want this work to look like in the future. But we essentially have representation from our state government agencies that either have oversight over our healthcare workforce through credentialing and licensing, and or have some aspect of population health and public health as part of their mission. So Department of Health and Senior Services, Department of Mental Health, Department of Social Services, and the Missouri Medicaid program, of course, the Division of Professional Registration. And I'm probably gonna miss somebody because I'm looking at my slideshow, not my notes, but just know that we work very hard to the governor's office. We do have a representative on our group right now from that perspective. Higher education and training programs. So both a representation of schools, that both public and private, that train different roles in our healthcare workforce, and also the coordinating board for higher education. Missouri is a complicated profession and occupation training state. There are many different programs, both in higher education institutions, and there's still a few associated with health systems. We want everyone to have a seat at the table, and sometimes a side benefit is conversations get to happen that wouldn't necessarily have otherwise. So we're glad to do that. We also very intentionally want to work with our professional associations, advocacy networks around healthcare workforce, and healthcare delivery networks themselves also. It is somewhat of a gap, and one that I've only been thinking of recently about how to integrate, but it would also be nice to understand a little more about the perspectives of managed care and some of those kind of organizations on what they need and consider priority within their recruitment efforts and that sort of thing. And then, of course, the licensing and credentialing entities. So we've been working on this for a little while, and trying to figure out the most effective, efficient, and affordable way to have to develop a longitudinal data system across our workforce professions and occupations. And it became clear that one thing that made it complicated to be successful at was working within, or between, I should say, not within, working between all of the different licensing and credentialing entities in the state. So we devoted, I think it took us 3 sessions at getting some legislation passed, actually added to the Division of Professional Registration statutes, some language that allows the licensing boards out of the Division of Professional Registration to collect workforce characteristic data, or to work with other institutions to do that work, or other entities to do that work, and do an analysis of it. It has some language that tells us what we can do with the data. It stipulates that the boards and committees and DPR are ultimately the owners of the data. It stipulates that user fees can be used to support the work, and encourages interagency cooperation around doing it, which I'll come back to here in a minute. And it also specifically excludes analysis of compensation or financial data at the professional individual role. So we can look at everything essentially, but how people are paid. if you will. And that's important for two reasons. Sometimes it feels like a big missing chunk, but on the other hand, that's the work of economists, really, to understand those characteristics. And also, it was simply a no-go from either the perspective of the Missouri Assembly that ended up passing this, and quite honestly, from the Division of Professional Registration or the agency perspective itself. So now I'm going to switch gears a little bit and talk about the kinds of data that we collect through the surveying of Missouri's occupations and professions in the healthcare workforce. And HRSA, as I mentioned at the beginning, has really led the way at a federal and national level in setting the standards and setting the table to do this kind of work. And they have adopted and recommend, based on collaboration with national boards, councils, and associations, minimum data set surveys for this list of professions. And we have adopted those here in Missouri to the greatest extent that we can. And I don't think I said when I introduced myself, but the Center for Health Policy is also part of the newly emergent Office of Health Outreach, Policy, and Education. And as such, we're working collaboratively between some different divisions, including the Rural Track, the Center for Health Policy, the Missouri Telehealth Network, and Sherry McDonald, who is our moderator here today, is working on this project that we're looking at here. And she did the lion's share of the work last year through a grant from HRSA to look at increasing rural providers in the state of Missouri and pulling together all of these different minimum data set surveys, building crosswalks so that we understand concepts between surveys, normalize them as we can, or at least understand how different professions and occupations talk about themselves and each other, with the long-term goal of being able to talk about an integrated workforce and how pieces of the workforce need to fit together in order to provide reliable, quality, accessible care. The other thing that we made a decision to do, well, two other things that we made a decision to do as part of this HRSA work is to go ahead and identify the occupations and professions in Missouri that don't currently have an established minimum data set survey through HRSA or through their own national association, and develop surveys. And the other thing that we determined to do is, what was I just going to say about that? Well, I will flip back to this in a minute. I changed what I was looking at. Now now I lost track of what I was talking about. I know what it was to move all of our surveys into REDCap, which is a survey software tool out of Vanderbilt University that is open source to public entities doing research. And we made that strategic decision to minimize for the long term the cost of doing this work on an ongoing basis. And so we're moving those surveys online as part of our support through the HRSA grant that the University of Missouri has received. We're developing new surveys and we're implementing our existing surveys. So if you think back to where I started with the timeline, we spent a lot of years sort of moving toward our ability to really jump in this context, and I'm very glad that we were prepared to take that on. So I'm sharing this slide so you can get a sense of the full range of occupations and professions here in Missouri, how they're sort of organized or not, if you will. And also to point out, I've talked a lot about the Division of Professional Registration. The other primary credentialing board in the state of Missouri is mostly around behavioral health occupations and professions. It is a 501c3. It's been around since the late 1970s, started out with a focus on alcohol treatment, and it's aligned with a national credentialing body and works to their standards, and has an administrative affiliation with the Department of Health and Senior Services, but is an independent organization. And the most recent and important occupation that has been added to that are community health workers. So that's where they get credentialed here in Missouri. So what do we do with this? So for the last couple of years, we've been doing some surveying with the minimum data set surveys in a couple different ways. The first way is through REDCap, as I described. We've done a physician report and have a second annual report coming out at the beginning of May for that group. We've done a physical therapy and PTA report, and for that we also do our data collection. For nurses, we have a relationship with the Board of Nursing that uses NurseSys, which is a national tool, and I know I have a bunch of nurses here, so feel free to chime in if I don't get this exactly right. But it's part of their accessing nurses is part of their national compact relationship, and essentially, when nurses in Missouri receive their notification that it's time to update their license, they must go through the healthcare workforce questions for nurses in order to get to the licensing place. Thus we have response rates in nurses over 95%, and it's a very solid data set. The other important thing to note about that is that based on the way the statutory language came out around this is technically we can't require in Missouri, but we can encourage. So if the way Lori Scheidt, the executive director of the Board of Nursing, describes it here in Missouri is that if a nurse calls her on the phone and asks for a paper license registration form to be sent to them, she will do that. But otherwise, they work through the nurses system. And then we do data analysis for them by having them provide us an annual copy of the data set specific to Missouri. It's a very high quality product, and I would suggest a very clean data set. It's a good model. This is a map I wanted to share just for a minute to give you a sense of some of the things that we can take on based on the survey data. And this is from our last physicians report that came out about a year ago. Of course, understanding the population density and accessibility is important to policymakers. So we look at both counties and core-based statistical areas. This is measuring what respondents to the survey report as the number of direct clinical patient hours per week that they provide, and are the dots in here, the gradation of dots are actually mapped at the zip code level, and the county lines are just to help you place yourself as you take a look at it. We do break out and do maps specific to the Springfield, Kansas City, St. Louis metropolitan areas, so you can get a little better sense of that. And this map that you're looking at is from our first report. And the one that we are about to release, we actually worked with a health economist to develop one, to check and ensure that our essentially convenience sample, how representative or not it was of the distribution of the workforce, and then to create some estimates for us that will give people a little better sense of what's happening in their locality. Which leads to another lesson learned that we have had, and that is that there's a great deal of variation between the perspectives of boards and committees on how they would like to prioritize the data collection process. So I just described how we work with nurses and what an effective data collection structure that is. Other boards and committees have chosen to make the survey available and not go into it from a sampling or a population strong encouragement or requirement perspective. And that is, of course, a project policy issue that we're working through. So it's a marathon, not a sprint. And our current goal is to not quite think of these as pilots, but to know that they're not fully there and that we are building the trust and relationships so that we can get to a point of having consistent data sharing standards between boards and committees to understand each workforce. And then I've got just a couple quick slides from the nursing report. We ask questions about what type of nurses they are and where they practice and what are their characteristics of practice in terms of both geographic location and practice setting. As you might expect, there's a lot of curiosity and policy making that needs to understand the age distribution of nurses. All of these categories, all nurses, LPNs, RNs, APRNs, approximately 30%, a third of their workforce are over the age of 54. We're watching this carefully across time. The different hash marks give you a sense of population density in those counties. And then I included this because we released the PT report recently, about half a year ago. And one of the nice things about developing a longitudinal system is that you can respond to unexpected circumstances. So one of the things we wanted to know is how practice had changed for this profession during COVID, since PTs tend to be very physical in their contact and interaction with people and with their patients and clients. And as you can see, their use of telehealth changed significantly in response to where we were in the pandemic. So we're watching that trend closely across our professions. So just a couple slides to say what we're currently up to and what we're going to try and get done in this HRSA grant that we will be able to utilize through 2023. As I mentioned earlier, we're doing a strategic planning process with our advisory group with a real focus on what does this project look like in the future? How is it, how do we codify or formalize the collegial relationships that come together to do this work? As I mentioned, Sherry and other members of that team are working very hard on developing surveys, testing, field testing, all of those pieces. Our goal is to have fairly standard report templates for the actual surveys and eventually shift our analytical attention also to doing policy analysis about emergent issues. And the other thing that we are getting to do is a significant upgrade to our web application. And we anticipate that being released and updated by around July 1. We are shifting from how about I say it that way as a non-programmer, to using a dashboard system that will include Tableau as a resource to present data, as well as Arc Online. We'll still have as a resource a lot of downloadable and accessible data sets for people to do analysis, but we're going to shift more toward a storytelling, story maps, dashboards, that sort of thing, to lift up what we learn about the characteristics of the workforce. And in the coming year, so this is very exciting to us, is the grant is scaled in a way that we'll be able to offer the professions and occupations through the licensing boards and committees to do their surveys on the grant funding. And so we're sort of working through the details of how that is going to work, as well as their analysis of that. And then we're going to focus on the more administrative and policy issues around where the project might be in 5 years or 10 years. So how it would be useful to support this work. One is, I mentioned earlier that we have been thinking of our advisory group as a group of like-minded and sharing a common interest folks since about 2007. So I want to extend an invitation. If you're interested and want to help with this work, we would love to have you. It would be helpful to advocate for the value of this work, and include and encourage institutional support for working in a collaborative process. As we probably all know, big entities and states can tend toward siloing just as a way to be effective and get work done. There's effort and social capital that gets spent on working collaboratively. If these data are important to understand your workforce, it's worth advocating for this kind of participation. And then also encouraging your professions and occupations to respond to workforce survey questions. Most of these surveys are designed to, be in the 15 to 20 minute range for respondents. And we're structuring so that if they've given us information that won't change, like where you went to graduate school or what year you got your license or how old you are, those sort of things, update, or, the data stays with the respondent so that they don't have to re-respond each year or each licensing period. So it's not an onerous process, and the better response rates we have, the better our analysis will be.